So welcome everyone to our AFMC response to the opioid crisis presentation on chronic pain in the elderly, presented by Dr. David Lussier. I want to take this opportunity to have each of you reflect on where you are sitting today, as we acknowledge that we are in the traditional unceded and unsurrendered Algonquin Anishinaabe territory. Next slide. A reminder that the funding for this project has come from Health Canada, but the views expressed herein do not necessarily represent those of Health Canada. Well, a special thank you again to the program's planning committee, who are listed here. Next slide. And here are the disclosures from the members of the planning committee for your reference. Next slide. Again, we just want to make certain that that all of you know that part of this is part of continuing medical education. It provides information and opinion, but does not replace good clinical judgment. Next slide. And again, a little bit of helpful information. We are providing transcription to this session, so you can toggle around to find that if that's a helpful tool for you. Please submit your questions during the presentation using the Q&A function located on your Zoom toolbar. We'll be able to turn on video and audio during the Q&A period, so you can also use the raise your hand function if that's preferable. We are being recorded and capturing audio and video, and the recording and the slides will be posted in the CPD Program Center within the week. Just to mark your calendars, Thursday, September 22nd at 12 p.m. Eastern Standard Time, Dr. Kudrina will be presenting on advanced knowledge of pain management. Just want to take a very quick moment to introduce our speaker. Dr. Lussier is, my apologies. There we go. Dr. Lussier is an associate professor at the Université de Montréal and adjunct professor at McGill University in Montreal. He's a practicing physician at the University of Montreal Geriatric Institute and at the McGill University Health Center, where he has developed pain clinics especially devoted to older patients. He is the founding chair of the Special Interest Group of the International Association for the Study of Pain on Pain in Older Persons. Dr. Lussier's research interests include pharmacology of analgesics and new approaches to manage pain, with a special focus again on older persons. He has written several review articles and book chapters on the treatment of pain in older patients and patients with cancer, as well as on adjuvant analgesics. He is co-editor of a book entitled Pharmacology of Pain, published by the IASP Press in 2010. I'm very much looking forward to Dr. Lussier's presentation, and we'll turn control of the microphone over to him.
Thank you, Lisa, for the introduction. Let me first share my screen. Very good. So this should be working. Very good. So thank you. Happy to be here to talk about chronic pain in the elderly. So what we will do today is first to acknowledge that as Lisa said, the views expressed do not necessarily represent the view of Health Canada, even though this project was made possible by financial contribution from Health Canada. I do not have any financial disclosure or financial interest whatsoever in what will be discussed in this presentation. So what we will do today is talk about chronic pain in the elderly. So how often older persons feel chronic pain? What are the main causes of chronic pain in old people? How to assess pain, and then we'll move on to treatment with non-pharmacological and pharmacological treatments for pain. And at the end, we will discuss briefly the opioid use disorder that we can see in older people. So how often do old people feel pain? There was a very interesting Australian study done by Fiona Blyth a few years ago that showed that the risk of having chronic pain increases with age. This is true for all types of pain. It's true for neuropathic pain, it's true for back pain. There's only one type of pain that does not increase with age. Actually, it might decrease after menopause, and mostly in women is headache, but all other types of pain, the prevalence increases with age. We can see on this graph here that it's more frequent in women. This was the Australian study, but the Canadian study showed almost the same thing. In the Canadian study, they asked people if they had pain of moderate or severe intensity present several times a week. And this was the case for 31.5% of women and 22% of men. So we see here that it's more frequent in women than in men. There are several reasons for that. And we see that there might be a little decrease in older men. The same thing was found in the Canadian study. So men 70 years and older might have a lower risk of having chronic pain than younger men. We think that this is probably more a generation bias than an actual decrease of pain in older men, or it is maybe what we call a survival effect, meaning that men who live past 70 years old have a lower risk of having chronic pain. So what causes pain in older people? The most frequent cause, I would say this is probably 75% of chronic pain in older persons, is musculoskeletal pain. So the most frequent cause is back pain. It's very, very common in older people. And the difference in old people compared to younger people is that when you're older and you have pain, you're more at risk of having several reasons to have pain, several causes of chronic pain. Whereas younger people, when they have chronic pain, they usually have just one cause of pain. They had a sports injury, they had a work accident or an accident, they have one disease. When you're old, you often have several diseases causing chronic pain. So for the back pain, it's the same thing. Several people have different causes of back pain, like spinal stenosis, facet arthritis, disc disease. A lot of people have surgery and they still have pain after surgery. So this is what we call the fade low back surgery syndrome, which is a very difficult pain to treat. Also, the joint pain is very common, osteoarthritis, inflammatory arthritis, and the neuropathic pain. Sometimes people think that neuropathic pain is not as common in older people, but it is very common. The most common causes are the post-traumatic neuralgia. We know that older age is the main risk factor for having post-traumatic neuralgia after a zoster episode. Peripheral neuropathy, like from diabetes, from alcohol abuse, from some medications, from vitamin B12 deficiency, the post-stroke pain, and the complex regional pain syndrome, which is a new term that we use to call what we used to call algodystrophy or reflex sympathetic dystrophy. And then cancer pain, of course, which we can get at any age, but more frequent in older people, as cancer also gets more frequent with age. What happens to pain perception when people get older? Several years ago, we thought that there was presbyalgia, meaning that there was a diffuse decrease of the pain perception in older people. Just as when we get older, we see less well, we often hear less well. So we thought that we also felt pain less well when we get older, probably from some kind of degeneration of the nervous system. So we've had studies trying to understand what happens to the pain perception when we get older. The results from one study to the other are very inconsistent. There's a lot of variability from one study to the other. What we see is that in several studies, there might be a very mild increase in the pain detection threshold. So what we do in these studies is that we put someone's hand on a hot plate, we increase the temperature of the plate, and then we check 3 different thresholds. The heat detection threshold, this is when the person feels that it's warm. Then we measure the pain detection threshold. So when it's become painful, and we measure the pain tolerance threshold. So this is when the pain is so severe that the person can't take it anymore and has to withdraw his or her hand from the plate. So what we see in the studies is that there might be a mild increase in the pain detection threshold. So the plate has to be a little warmer for the person to feel the pain. However, there's a lot of variability from one study to the other, so it's very hard to conclude something from that. What we know for sure, though, is that there's a decreased endogenous pain inhibition. The endogenous pain inhibition system is very important to control pain. What happens when we feel pain is that the pain signal is transmitted from periphery to the brain and then activates several descending inhibition pathways that will decrease the pain sensation. So this is one of the main mechanisms that control pain, and this is why we don't have pain everywhere all the time. So we know, for example, that I'm sure you've a lot of people have experienced this. So if you have a chronic pain, let's say you have a backache, and then you have an acute pain like a toothache, or you have surgery. After surgery, you don't feel the chronic pain so more because the acute pain is more severe. So it activates the pain inhibition pathways and it decreases the chronic pain intensity. So this is true in younger people. What we know is that in older people, it doesn't work as well. The way we study that is that we put someone's hand in water so cold that it's painful, and at the same time, we create pain on the other arm with electric shocks or heat. So in younger people, and this has been shown in animals and in humans, in younger people, when you put one hand in the cold water and you create pain on the other hand, the pain is milder because it activates the pain inhibition pathways, so you don't feel the pain as severe in your left hand when you're younger. This doesn't happen in older people. So this might be a reason why older people might have pain at several different locations. And what is very interesting is that this is one of the mechanisms that has been identified as contributing to fibromyalgia. We see a lot of older people who have chronic muscle pain, and they often get a diagnosis of fibromyalgia. But fibromyalgia is a disease that we see more in younger people. This that we see in older people, it would be very uncommon to develop fibromyalgia at 80, 85, 90 years old. So this might be a similar phenomenon that we see, that they have a lot of pain in the muscles from the descending inhibition pathway dysfunction. And this is important to understand that because it will be relevant when we talk about medication management of pain, because we might choose medication that will work on these inhibition pathways. For example, we know that the inhibition pathways is mediated by several mediators, but mostly by noradrenaline and serotonin. So this might be why duloxetine, for example, will be a very good analgesic to use in older people. So moving on to pain assessment, or before that, we talk about the impact of pain in older people. So we know that chronic pain has a lot of impact, and this is different in older people because they often have several other diseases, and they're often more frail and more fragile. So the chronic pain might have a greater impact in these people. So we know, of course, that chronic pain will cause functional impact. So it will decrease their ability to do activities of daily living, decrease the walking ability. It can increase the risk of falls. So this is something that we have to look for and take care of in older people. We also know that chronic pain can cause depression, can increase anxiety, can decrease quality of life, and can decrease the will to live. There has been a lot of debate in the literature to know, is it the chronic pain that causes the depression? Or is it the depression that increases the chronic pain? And we have studies going both ways. So what we know now is that if we want to control pain well enough in somebody who has depression, we have to treat the pain and the depression. So chronic pain has a lot of effective impact. It also has an impact on sleep. And here again, the interaction is both ways, because we know that chronic pain can interfere with sleep. And we know that if we don't sleep well, we increase the risk of having chronic pain the day after. So it is, again, very important that all the people with chronic pain sleep well. So if we want to work on that, we will use mostly non-pharmacological measures to improve sleep so that they sleep better and they might have less pain afterwards. And now this impact will be mediated by several other variables that we see in everybody. But as I said, because older people are more frail than younger ones, it is even more important to consider these other variables. And these are the comorbidities, because if you have only chronic pain, you won't have much impact. But if you add chronic pain to the other diseases, it might have much more impact. Cognitive functions. We know that chronic pain can decrease cognition, can sometimes mimic even cognitive impairment. And this is probably related to attention, because if you have chronic pain, it's hard to focus on learning new information. So because you cannot learn the new information, you won't be able to retrieve it. So by improving the chronic pain, we might help the cognition. We know also that the cognition can impact on pain sensation or on pain expression. People have a long time wondered if people who have significant cognitive impairment feel the pain the same way as people who don't have cognitive impairment feel. So they did studies using the same plate as we use for the pain detection threshold. And what we know from these studies is that there's not much difference in the pain detection threshold in people with cognitive impairment compared to people with no cognitive impairment. However, the way to feel the pain and the way to express the pain is modified, because a lot of people cannot express pain. So we'll get back to that later. And then the other variables that can modify the impact of chronic pain are the coping strategies. We know that to have a good control on your pain, you have to use active coping strategies. So we have to do something. You do exercises, you change your mind, you do yoga, you relax. This is much more efficient than a passive strategy, which would be to have a massage, to take a pill, to have an injection. We also know from studies that older people tend to use passive coping strategies more than active strategies. So we'll talk about that a lot later, but the most important thing when we want to establish a pain management plan for chronic pain in older people is to have an active pain management plan where the patient will be a partner of this plan. And then the other one is the pain belief. So what does the person think about pain? If they think that there's nothing that they can do, if they think that pain is the worst thing, if they have catastrophization, if they think that you have to suffer before dying if you want to go to heaven. So these are pain beliefs that we see, and we have to correct some of these false beliefs. So how do we assess pain intensity in older people? Of course, we can use the same scales that we use in younger people. We have studies suggesting which ones are good and which ones are not good. So as in younger people, it's better to have self-assessment. So to ask the person to rate the pain on a scale. The easiest one to use is the verbal descriptive scale. This is a very simple way to ask about pain. So how do you describe your pain? No pain, slight, mild, moderate, severe, very severe, and most intense pain imaginable. And you can also have a lower number of choices. You could do no pain, mild, moderate, severe. So you can have just as many choices as you'd like if you want to have a very precise assessment, or if you have just a broad assessment. What is important here is two things. First, we know that older people have more trouble than younger ones to assess pain on a medium-term basis. So it's better to ask about pain that they feel right now or pain that they felt yesterday. If you ask them, what is your average pain in the past 2 years? It's very hard for a lot of people to report that. So it's better to use a limited period of time when we want to assess the intensity of pain. Also because a lot of older people, as we said, has musculoskeletal pain, and they have less pain when they're at rest than when they're moving. So if you ask them what's the average pain, it's very hard to assess, because if they are sitting, they have no pain, but if they're walking, they have severe pain. So the scale, of course, has limits, as all scales. The other very easy one to use is the verbal numeric scale. There's a mistake here on the slide, sorry, on the scale from 0 to 10, of course, where 0 means no pain and 10 means the worst pain possible. How would you rate your pain? Again, this is very subjective. So for one person, 2 is 8 for the other one, because the pain level that we would imagine is different for everybody. But this scale is not there to compare one person to the other. It's used to compare one person to himself or herself to assess the efficacy of the pain treatment. So this is why once we start using a scale, it's better to keep using the same one to compare the same person with the same scale. And then one scale that we see recommended sometimes for older people is the FACES scale. So sometimes we say if people have trouble using words or numbers, we might just use a drawing scale with the faces. This is very hard to use in people with cognitive impairment. Because they have trouble interpreting what each face means, but for some people it works. So we can use it, but studies have shown that it's not always as reliable. So the best scales to use would be the descriptive scale and the numeric scale. As I said, older people who have significant cognitive impairment cannot report pain the same way that other people do. They cannot assess the pain intensity or report it using a scale. So sometimes we have to use nonverbal pain behaviors, like facial expressions. If you have a slight frown, a frightened face, a wrinkled forehead, grimacing, distorted facial expression, these can be signs of pain. People who are crying, who are calling out, who are moaning, asking for help, this can be a sign for pain. And then body movements being restless, increased pacing, rocking, this could all be signs of pain. Changes in interpersonal interactions. So someone who's aggressive, combative, resisting care, it might be because he has pain when he's given care. Changes in activity patterns or routines. Somebody who's usually wandering and walking around all the time, and at some point keeps sitting all the time. Maybe it's because it's too painful to walk and wander. Someone who's usually agitated, maybe it's because it's too painful when he gets agitated. So it will be quieter. So all changes in activity patterns or routines could be a sign for pain. So this is just to alert us to possible pain in older people with cognitive impairment. We have several scales that have been developed and validated to assess pain in these patients. The problem is that it's very hard to differentiate between agitation or delirium, for example, and pain, because they can present almost the same way. So when we have someone who has a change in his activity patterns, who's agitated, who has this facial expression that might be caused by pain, we should look out for pain causes. If we don't find any, we can treat the pain, like using acetaminophen, using non-pharmacological measures, and see if the behavior will get better. So again, if we want to assess and have a good assessment of the pain in one person, we have to assess all these different dimensions. This is how we will understand what the pain means to one person. And also, when we want to treat the pain, we will try to act on each of these different variables. So we will try to improve sleep. We will try to improve the coping strategies with, for example, the cognitive behavioral therapy. We will try to reduce the affective impact by treating depressive and anxious symptoms. We will try to reduce functional impact, because sometimes we can't decrease the pain intensity, but we can improve the function. So this will also be a gain for the patients. So how should we manage chronic pain now? As I said before, the most important thing is to favor active approaches, encouraging patient empowerment and engagement in the pain management based on the patient's objectives. Because for some people, what will be important is to have less pain. For others, the intensity of the pain doesn't matter so much, but they want to be functional. For some people, it doesn't matter if they're sleepy, for example, from the medication to make the pain better. But others will want to stay very alert and can tolerate higher levels of pain to make sure that they stay alert. So we have to always discuss the treatment plan with the patient and base the treatment on the objectives. Of course, an interprofessional approach is always better. So all members of the interdisciplinary team can have a role in managing the pain. And it is very important that we involve as many people as possible. It's way too easy in our medical system to prescribe medications, and it's sometimes much harder to involve a professional that can provide non-pharmacological measures, but we have to make a point of using all the members of the team and all the approaches that we can to improve the pain. And of course, at the center and around this are the patient and his or her family, because they will be partners in managing the pain, and we will have to discuss the pain management plan at each step. So if we want to control pain well, we have to use different types of interventions or different types of treatments. The non-pharmacological treatments that we will discuss, the pharmacological, so medications, interventions, and the specific treatments that will treat the cause of the pain. So we'll talk about each of these different measures. The non-pharmacological treatment will include mostly the physical approaches and the psychological approaches. What we can use as physical approaches is what a physiotherapist can do, what an occupational therapist can do. And there are ways that they can help the pain with passive measures like heat, cold, massage, tense. But again, what is most important is that the person becomes active. So doing physiotherapy once a week, you go there, you get a massage, you get ultrasounds, you get a tense. It can help the pain for a little while, but the pain relief will not last all week. So what we have to do is that what is done in the physiotherapy or occupational therapy becomes part of a self-management program that the person will do by himself or herself at home all week. So if the tense works, the person has to know how to use the tense. The most important way to control pain and prevent functional deterioration in all the patients is, of course, exercise. So we have to focus a lot on exercises to improve the pain. It also prevents deconditioning. It prevents increased pain, because if you don't move, you might get frozen shoulders, or you have more pain because you have stiff joints. So we have to do exercises. This is the most important thing to do. And the psychological approaches, we can use the cognitive behavioral therapy, which is the most studied psychological approach to pain. So change the way the person sees the pain, decrease catastrophization, have a more positive attitude towards pain and the possible pain relief. So this is very effective. It has been studied in older people, and it has even been studied in older people with cognitive impairment in long-term care centers, and it works if we adapt the program to these patients. The other type of approach that works very well is a mind-body therapy, so yoga, tai chi, relaxation. So these are techniques that can work very well. And sometimes people think that if the relaxation or the distraction works for pain, it's because the pain is psychological. But we know by studies from functional MRI that if you decrease your attention to pain by distraction, it decreases the activity in the brain centers of pain, and it will improve your pain. So these are very effective measures that we should be using. The one that is less helpful, less effective is the emotional disclosure or the support therapy, where you see a psychologist or a therapist and you see how bad it is for you to feel pain. It can make you feel better for a little while, but it does not have any carry-on effect. So the cognitive behavioral therapy, the mind-body therapy are the best ones to use as a psychological approaches. There are several types of interventions that we can use to treat the pain. So we can do injections in joints, steroids, hyaluronic acid. Now what we see a lot used is the platelet-rich plasma. So these are all techniques that we can use, and one will be more effective than the other depending on the stage and the severity of the arthritis. Of course, we can also inject a tendinitis, we can inject a bursitis. Some people do trigger points, we can do Botox to relieve muscle spasms. We can do spine injections like facet blocks, epidurals, medial branch block, and we can block peripheral nerves. So these are all interventions that we can use to treat the pain. And sometimes people say, I will not do an epidural in someone who's 95 years old because it's too aggressive. But I think it's much less aggressive to do an epidural if it works than giving a pill every single day with all the side effects from it. So we should always try to think, is there an intervention that I can do to relieve the pain at the site of the pain and spare the systemic adverse effects of medications? The specific approaches will be the treatment of the cause of the pain. So for someone who has arthritis, it could be a joint replacement. For someone who has back pain and spinal stenosis, it can be a laminectomy or fusion. Again, age should not always be the sole criterion to base the decision on should I operate or not. Because if you're 80 years old and you have severe knee pain from severe arthritis, the arthritis and the pain will not get better in the next few years. And if you're 80 and you're in good health, you're probably going to live up to 90 or over. So oftentimes it's worth doing the knee replacement. And it's always better to use it sooner than later because you don't want to wait 10 years because you'll be even older and the risk will be higher. So we should always think about surgery, even in old people. So now moving on to medications. There are lots of medications that we can use to treat pain, but are also very limited. And the problem is that there's very, very little improvements or developments in this field. So except maybe for the medical use of cannabis, I would say that nothing really changed in the past 15 or 20 years in the medications that we have available to treat pain. So it's at the same time very simple and very complex, because once we've used the same medication that we use all the time, it's very fine-tuning and it can be hard to treat the pain. So we should always, especially in older people, we should always choose a medication with the best efficacy adverse effects ratio. I always see it as a risk-benefit thing. If we use a medication, will it cost me more in side effects than it will give me in pain relief? So for example, medications that will help but have a lot of side effects, or for example, gabapentinoids, pregabalin, and gabapentin, we will talk about these later. But if I give them in the morning, I will have a lot of sleepiness, sometimes falls, confusion. So it's much better to keep them only at night and then spare my adverse effects during the day. I would also discontinue medications with poor ratio like benzodiazepines that we should never use in older people, but several of them have been taking them for several years, so we should try to stop these. It's also better to use combination therapy rather than monotherapy. We do this in medicine now for almost all diseases. We use several antihypertensives with different mechanisms of action to have a better control of the high blood pressure. Same thing for the pain. It's better to use different medications with different mechanisms of action to get a better pain control with less adverse effects than if we use one medication at a higher dose. We should treat the comorbidities. This is the most important thing to do. Sometimes I have, as Lisa said, I have a geriatric pain clinic, a pain clinic for older people. And sometimes I get referred patients who have been followed at a regular pain clinic for many years, and where people don't know what to do anymore, and they're pain specialists. And when we succeed to do something that they couldn't do, it's always by treating the comorbidities. So depression, anxiety, sleep, cognitive impairment have the general biopsychosocial and treat all comorbidities. This is the way we should always address the old patients with chronic pain. And then we know that our motto in geriatrics is start low, go slow. So we start with a small dose, we increase slowly, being very attentive to side effects. But now I like to add start low, go slow, but go somewhere. So if the person has chronic pain, we should not always be afraid of increasing to a therapeutic dose. Keeping a very small dose of a medication that does not do anything and does not cause side effect is useless. So we should try to increase if we can without having too many side effects. So I said we should use combination therapy, so different medication with different mechanisms of actions. So what we have is non-opioid analgesics and opioids. We used for many, many years to talk about what we call co-analgesics or adjuvant analgesics. More and more, we tend to avoid this category, or rather this name for these medications, because an adjuvant analgesic is a medication that was developed for something other than pain, but we can use for pain. But now most analgesics have been shown to work with pain, and some of them have been developed and have approved indications for pain. So there are nothing else than non-opioid analgesics. So now we include them in the non-opioid analgesics. So the non-opioid analgesics will be the acetaminophen, NSAIDs, the what we used to call the adjuvants like antidepressants, anticonvulsants. So we'll get through these. Acetaminophen, which is the most commonly used analgesic by older people. We know that the half-life is a little longer in older people, so we don't have to give it every 4 hours. We can give it 4 times a day with a good pain relief. We have the sustained release form, the 650 milligrams that we can use only twice a day or 3 times a day, so we don't have to take the medication as often. We have to be careful with the side effects, of course. The most frequent one is a liver toxicity. So we know that the risk of having a liver toxicity with acetaminophen is higher when we get to a higher dose. This is why now most people recommend not to go higher than 2.6 grams a day of acetaminophen in older patients, because if we get to a higher dose, we have a higher risk of having liver toxicity. If we want to get to a higher dose, we have to be sure that this dose is more effective. Like, for example, if we want to give 1 gram 4 times a day, we have to make sure that it works better than giving 650 4 times a day or 500 4 times a day, to make sure that we have an added benefit of having a higher dose. And then we should monitor the liver enzymes on a regular basis. We have to be careful now with the new forms of acetaminophen. There's a form that's called back pain or body pain night. These two are the same, and they have methocarbamol with the acetaminophen. And the methocarbamol is, we'll talk about that later, but it's a so-called muscle relaxant. So some people say that it relaxes the muscles. It does not actually relax the muscle, but it creates a lot of sedation and somnolence, so it can cause confusion. So it's not a good one to use in older people. And the other one that we have to be very careful with is the one called NIGHT, because it has diphenhydramine with the acetaminophen, and the diphenhydramine will make you sleep because of a side effect that is somnolence, but it can give you a lot of side effects the day after, so we have to avoid that. NSAIDs. I like this quote from the American Geriatric Society because I think it summarizes very well. It says that non-selective NSAIDs and COX-SIBs may be considered rarely and with extreme caution in highly selected individuals. So what this means is that we have first to use other treatments like acetaminophen. We have to make sure that the person does not have any absolute contraindication like anticoagulants, chronic renal failure, because the most frequent adverse effect of NSAIDs in older people is the acute renal failure and the hyperkalemia. We have, of course, the gastric toxicity, but we have to be very careful about the renal function. And even if one person takes an NSAID now and does not have any renal problem or any cardiac insufficiency problems, it's when we will add something else, like an ACE inhibitor, they will get dehydrated from a small infection or just from heat, and then they will get the acute renal failure. So we should really restrict the NSAIDs to acute inflammatory pain. If you have a tendinitis, if you have inflammation or bursitis acute, then you can use an NSAID. But for chronic non-inflammatory arthritis, we should not use the NSAID because the risk is too high. And the other non-opioid analgesics, duloxetine is really the one that we have the most studies on. So duloxetine is an antidepressant that also has anxiolytic properties, but we have a lot of studies showing that it works for diabetic neuropathy. It's also approved by fibromyalgia. It's approved by Health Canada for low back pain and for knee arthritis. And as I said before, older people have a decreased pain inhibition pathway, and the duloxetine will work on this. So it will improve almost any type of pain in older people, even though it's approved for the 4 indications that I mentioned. So when we want to use a duloxetine, we should start at a small dose. And if it's well tolerated and we don't have someone who's very small and very old, we can usually increase to 60 milligrams. And then we follow the response. It often takes at least 4 weeks to be able to assess the response. Gabapentinoids are very good analgesics that we usually reserve for neuropathic pain, although the pregabalin is approved for diabetic peripheral neuropathy, post-traumatic neuralgia, spinal cord injury, and fibromyalgia. We don't have much added benefit to use pregabalin, for example, in other types of pain like arthritis. I see it used a lot in arthritis, and there's no reason for that. Sometimes we see it used oftentimes actually for radicular pain from spinal stenosis, but again, studies have shown that there was no benefit to use pregabalin in these patients. And the pregabalin has a lot of side effects, especially if we use it in the daytime. So we should be very careful and mostly use it at night and at the smallest dose possible. Similar with gabapentin, but gabapentin does not have any Health Canada approved indications for pain. Sometimes it's better tolerated, so it's one that we can use. I'm trying to go a little faster because I see that time is going by very fast. Cannabis, so there's been a lot of interest in cannabis in the past few years. We don't have any good quality evidence for the analgesic effect of cannabis. It's not approved by Health Canada as a medication, so the patient has to be very, very conscious of that there is no, cannabis is not approved for pain or for anything else, actually, and that we don't have any good studies showing that it works. The cannabis, the people can get the cannabis at a store, just like we do for recreational use. But if they want to use the medical pathway, the physician has to authorize its use through a licensed producer, which will deliver the cannabis at home. When we want to treat pain, it's always better to use CBD because CBD has analgesic and anti-inflammatory properties rather than the THC, which is more causing more euphoria and dysphoria and more side effects like somnolence. So if people want to try it, they could try a CBD oil or CBD capsules to see if it works. It usually doesn't have many side effects if we use only CBD. I'll go over the cannabinoids just for sake of time. There are other non-opioid analgesics that we can use like this is like third line if we use everything else. They can be useful. I would say mostly topiramate, lamotrigine, oxcarbazepine for neuropathic pain. The ones that we should not use are amitriptyline. Amitriptyline is used a lot for neuropathic pain, but it has so many side effects and toxicity in older people that we should avoid it. And as I said before, all the muscle relaxants that can cause sedation and confusion. So moving on to the opioids. Indications for opioids in older patients are similar to the ones in younger patients, but of course they will cause more side effects because patients are more frail, they take more medications, so we have more drug-drug interactions, so we have to be careful. As in younger patients, we will not use them as first line. We will try safer options first. As usual, we will start with the lowest dose available. It's almost better to start with the short acting and then move on to a long acting if it's well tolerated. And we have very limited pharmacokinetic and pharmacodynamic data on opioids in older subjects. So we have to extrapolate from studies done in younger subjects and knowing what the pharmacological changes are in older people. So again, if we want to use an opioid, we should clarify the patient's expectations, not only use the opioid and assess the response. The response might be a decreased pain, but it can also be an increased functional status. Something very important that has changed in the past few years is that we used to say that there was no ceiling dose for opioids, that as long as the patient got better, we could keep increasing. Now we know, and the recommendations, the Canadian guidelines for opioids for chronic non-cancer pain recommend that we do not exceed the equivalent of 90 milligrams of morphine per day. So this would be a fentanyl 37, between 37 and 50. It's an hydromorphone 18 milligrams a day. It's an oxycodone, depending on what we use, probably something like 60 milligrams a day. So we should be careful not to exceed this dose, because first, there's no evidence that it works better. And second, we know more and more about the opioid hyperalgesia. So when we get to a higher dose, we could get more side effects. And if people are taking a higher dose, we should try to taper them to at least 90. And if we can, to stop the opioid. And I've been successful in doing this in quite a few patients who were taking very, very high doses, and we were able to decrease them to a small dose of opioid, and they feel much better. So we'll go over each opioid very briefly to see which ones are better. Tramadol, the main problem with the tramadol is that it has a lot of drug-drug interactions. So usually it's one we don't recommend in older people because of this. Morphine can be a good one, but it's renally cleared. Because there's a lot of chronic renal failure in older people, we tend not to recommend morphine. Also because it causes more nausea, more constipation. So it's not the best one to use. Hydromorphone could be a good one to use. Its metabolism is not impaired by age. Its metabolite has lower affinity for opioid receptors. Its metabolite does not cross the blood-brain barrier so well. So it might have less cognitive side effects. So it's a good one to use. However, it causes more constipation, more sedation. So we have to be aware of that. Another good one to use is the oxycodone. Oxycodone is also renally cleared, but less than morphine. Its half-life is not changed with age, and it causes less sedation than hydromorphone. The oxycodone is the only opioid that has a kappa agonist activity. So because of this, it might have a little euphoria, which we want to avoid because it might increase risk of addiction or misuse, but can be good because we might have less sedation. So if who has an older patient with chronic pain who's a little depressed, and a pathetic oxycodone might be a good one to use. Codeine is not good. We'll skip that very, very quickly. Not good. Lots of side effects, drug interactions, and not a good one. If we want to use a long-acting opioid, we could use, the best one to use is transdermal buprenorphine, which is a patch that we put on, we leave it on for 7 days. It's good because its metabolism is is through the kidneys. So it's not through the kidneys, sorry. It's metabolized by the liver. So there's no accumulation in renal failure. Its metabolism is not impaired by age. Its lowest dose is so low that we can give it to opiate naive patients, to most patients. So it's a very, very good one to use, the transdermal buprenorphine, for chronic pain if we want to use a long-acting opioid. Transdermal fentanyl can be a good one to use, but always as a second line. It's very, very, very potent. Even the smallest dose is way too high for an opioid naive older patient. We have the problem that the patch stays there. So if the person lives by himself, the dose gets too high, he might have a respiratory arrest. So we have to be very, very careful with the fentanyl. Always started only as a second line after starting another opioid. Methadone can be a good one to use in selected patients. I'll skip that because I want to move on a little more to the opioid use disorder and keep time for questions. So opioid use disorder, it can present in older adults as much as in younger adults, but it's often more subtle in older adults because sometimes it can overlap with the physiological tolerance that we get from the opioids. It could be mistaken for another medical condition. And there are several ways that older people can develop an opioid use disorder. Some have used illicit substances all their lives, so they've used heroin or opiates all their lives, so they just keep using it. Some have been prescribed an opiate for a medical condition, but the medical condition is resolved, so the healthcare provider does not prescribe the opioid anymore, and then the person turns to the black market to keep using the opioid. And some have been prescribed an opioid, but have started using it inappropriately to manage non-pain symptoms. And this is what I see the most frequently in my practice. So I just had one yesterday who's been using hydromorphone for many years to treat pain. And now she uses it because she says it relaxes her. Sometimes it makes them feel better. It makes them sleep. So we have to be very attentive because these are inappropriate uses of the opioid. There are not many screening tools that have been validated for older adults, so we can use the same ones that we will use for younger ones. How do we treat that? Same thing that for younger patients, the buprenorphine naloxone is often recommended now as first-line treatment for older adults with opioid use disorder. Methadone can be a good one, but as we said, there's a lot of, well, we didn't say that because I went fast, but methadone can accumulate in older patients because it has a very long half-life, very variable from one person to the other. So we can use methadone if we do it carefully. And now more and more, we see the daily slow-release morphine, the 24-hour form of morphine at a small dose that can be used for opioid maintenance at a small dose in older patients with the opioid use disorder. And just to conclude, how do we prevent the opioid use disorder? First, as we said, do not prescribe opioids as first-line treatment. You always use an interprofessional approach, so not only use medication. If we use medication, not only use opioids, use non-opioid analgesics as well. The smallest dose for the shortest period, and do not exceed the recommended daily dose of 90 milligrams of morphine equivalents a day. And do not use long-term opioid therapy unless we have severe chronic pain that interferes with function and quality of life. We have here a very good reference for opioid use disorder. They have guidelines, they have tools for patients, for families. So if you want to know more about opioid use disorder, this is a very good reference. And this concludes what we had to say. I'm sorry I went a little over time. So I think we still have 5 minutes or so for questions, maybe on anything, of course, but maybe on what I went through more quickly. So I think that if you have questions, you can just ask them in the discussion or the Q&R. I have one question here. Question is, what dose of hydromorphone to use in an opiate-naive patient with chronic knee pain not relieved by appropriate acetaminophen dose? Yeah, I didn't talk about doses. Maybe I should have. So for hydromorphone, for all medications, actually, we always want to start with the smallest dose available. So for hydromorphone, the smallest pill we have in the short acting is 1 milligram. So we could use half. I usually start with half, so 0.5 milligrams to use every 4 hours, but telling them not to use it every 4 hours on the first day. So the first day you take 1. If you tolerate it well, the second day you could take, when I say 1, it's 1/2. So the first day you take 0.5 milligrams. If it goes well, you don't have too many side effects, then you could try 0.5 milligrams twice a day. You see if it works, and you could go up to 4 times a day. I try to avoid going every 4 hours unless the pain is very, very severe. So it would be 0.5 for hydromorphone. If the 0.5 doesn't work, we could go up to 1, but sometimes it's hard. I would try to avoid going to 1 right away. So 0.5, then go up to 1. And then if 1 milligram, like 4 times a day, doesn't work, it's probably better to switch to a long acting than keep increasing the dose of the hydromorphone. Same thing with the other ones. So maybe go over the other ones. Oxycodone, short acting, the smallest dose is 5. So we could start with half, which would be 2.5. Morphine, it's easier. I said not to use morphine, but sometimes if we want to use small, very small doses, we can use a liquid morphine because it allows us to do like a 0.5 or even a 0.1 of liquid morphine. Yes, the morphine also, so I said 0.5, sometimes 1 milligram, so always the smallest dose. Then there was a cannabis slide that you skipped. Could we go back to that? It wasn't cannabis, actually. I'll answer the other one and then go back to that. What do you consider as elderly by age? Would you consider more of a biological age? So what we usually consider as elderly, it's very hard because everybody's different, of course. Usually we tend to consider 60 or 65s as elderly, but of course, as the oldest you are, the highest the risk is to have side effects from medication. So usually we say 60. For example, when I say not to use amitriptyline, the recommendations are not to use amitriptyline in people over 60 because you get a higher dose of side effects. Same thing with NSAIDs. Usually we say to be very careful over 60. So 60, 65 would be the age for elderly pharmacologically. But of course, when you get to 85, then the risk of frailty is much more. So we have to be even more careful. Can you tell us about platelet therapy for pain control? What diseases will respond? This is the platelet-rich plasma is something very new that a lot of people use, and we don't have that many good quality studies. So I wouldn't they are trying to answer this question precisely, but what we know is that it can decrease inflammation. So some people use it in joints to decrease inflammation from arthritis. Some people use it in tendons to decrease inflammation from tendinitis. So now we see it used in almost all conditions that have inflammation, but we don't have good studies for all these indications. So that's, I think, the best I could do to answer. There was a question here about the cannabis. People who are using CBD oil and have syncope, marijuana with heart disease. So cannabis and elderly, a lot of older patients want to try CBD oil because they think that it's natural, that it can improve almost anything. If you use the CBD, I did have a few patients with side effects, but most of them tolerated fairly well. The THC, though, causes much more side effects, so we have to avoid that. We have to be careful. Most people want to use it as oil. There was a question about the heart disease. Not sure it's for the smoked form, but for the oil, we don't see much side effects for the heart. And then there was a question about the platelet therapy IV. Sorry.
Dave, I'm going to have to cut you off, which really makes me incredibly sad. But perhaps we can, people can stay on for a few minutes longer. But I do need to sort of say, for those of you who need to leave right on the hour, you will get a post-program survey that'll be mailed to you. The recording will be available on the Program Center website within a week, and your certificates will be available by the 3rd of October. So I'm going to let the questions continue for a few minutes, but I just wanted to make certain that those of you that need to leave had that information. And I apologize, Dr. Lussier, for interrupting you in the middle of the questions that were clearly spurred on by your wonderful talk. And I'm really delighted that there's been such an interest in this topic. So I'll let you continue to answer that question, and my apologies for the interruption.
No, my apologies. I tend to talk too much, so I always run over time. There was a question about the IV platelet therapy. I must say I don't know what this is. So I've not heard about IV platelet therapy. Maybe what the person means here is what I'm talking about, the plasma-rich, the platelet-rich plasma, is what we do is we take the plasma, we take a blood test, like we take blood, actually not a blood test, but we take blood, then we have to centrifuge the blood just to keep the plasma with more platelets, and this is what we inject. But we don't inject it intravenous, we inject it in the joint. Maybe I wasn't clear. So we inject it in the knee, in the shoulder, we inject it in the tendon, in the bursitis. Some people use it after wisdom tooth extraction to decrease the inflammation. So this is what we do. I've not heard of IV platelet therapy. Yes, the person is asking if it's the person's own blood. Yes, you take the blood from the person, you centrifuge it, and then you inject it back to the same person. And it's done on the same session. It's a very easy thing to do. It's very expensive to do though, because there's a lot of manipulation involved. And then there's one person, I won't be able to answer that, about the fentanyl. Somebody who says he's on 150 micrograms an hour of fentanyl for the past 20 years. Am I in danger? Of course not. It's higher than the recommended dose now, but of course, as I said, recommendations are overall, and some people respond to a higher dose and do one in a higher dose. So I can't comment on a specific case, but if you're on 150 micrograms per hour of fentanyl and you're doing well, it might be a good thing to speak to your physician and see if you could reduce it. And if he and you think that it's not necessary, I don't think you're in danger at all at this point. I think this pretty much answers it all. So yes. So thank you, everybody. I hope I didn't miss anything. No. Okay, so thank you everybody for being here.